It's a case of our department with Professor Sadot. I will start sharing the screen.
I present you, Pietro. Nice.
So this is we talk here about a patient. Do you see my screen?
Yes, but yeah, perfect.
Okay, so we speak about a lady that is a 79-year-old that was presented to our department from the hepatology department with a new diagnosis of HCC. This is a patient who had the symptoms starting on December 2021. She suffered of abdominal pain and she performed regular blood tests. They found an elevated liver enzyme, so she was sent for CT. And on CT, this is not exactly the first CT, but on
Sorry,
CT,
the diagnosis of the lady, because I could not hear. She was diagnosed with.
So this is she was sent to the CT and she was diagnosed with this mass. Afterwards,
but the condition, the underlying condition, she was.
No underlying condition. She's healthy, and she only had 20 years ago a lumpectomy for breast cancer.
Right.
And no hepatitis viruses, no cirrhosis, no predisposing factors for any liver disease. And she was referred from her family medicine doctor to the hepatologist because of this tumor that we can see here. This tumor was biopsied, and it came back as a well-differentiated hepatocellular carcinoma. Her tumor markers showed CA19-9 467, CEA was 1.5, and alpha fetoprotein was 160. As I said, she has no past medical history of any predisposing factor to cirrhosis. And after an MDT meeting, we decided together with the interventional radiologist, after having measured the volumes of the liver, that she should undergo a left extended hepatectomy. And because of having a remnant liver less than 30%, we had a discussion, and she had undergone embolization of the left portal vein together with the left hepatic vein, and this is the post embolization CT that showed us an increase in her right liver, actually what is supposed to be a remnant liver, up to 38%. So the discussion here, if there is any further things, should I go from the beginning?
Nope, that's fine for me. The CT scan, I would like to see the CT scan down below the confluent to see the margin that you would have on the pedicle of the anterior sector. Yeah, good. Clear for me. Thank you.
Yes, so thank you, Nasser, for the presentation.
I didn't hear a question by Nasser.
So our question is whether you would have done this embolization, that's first of all, or you would have taken her straight to surgery. Second, based on the volumes I just presented. Second, if the fact that she had no other predisposing symptoms, predisposing factors to cirrhosis, if any further investigations was supposed to be done. So all the panel of virology was done by the hepatologist. They did really an extensive work, and nothing was found.
Yeah, right. But good questions, and I will turn them to the audience. Then I may have some additional questions for you, but let's.
May I say something, Pietro? Yeah.
Yes.
When we start to do chemoembolization for hepatocellular carcinoma, it was at the very beginning, and Pietro knows this perfectly well, how we did do it together. Objective was not only for this kind of large tumor to reduce the size of the tumor, but also to see if there are not small nodules near the tumor. It is not rare that when there is a huge tumor like this one, there is small nodule, which is sometimes 1 or 2 centimeters. And we must be careful about that, for they are small. And it could be that when we do the resection, the liver resection, even anatomical, we may let some of the small tumor,
behind, yes,
part of the liver.
Yeah. Now, if I understand correctly, this patient did not have a chemoembolization. She had a left portal embolization,
Yes.
but we did not see the previous CT scan on the basis of volume.
Yes.
So it's difficult for us to give you an answer, but there are certainly other things that I would have done before, on the line that Professor Bismuth is saying, before doing the embolization and before taking this patient for surgery. But these are maybe platitudes, but let's go and ask for others who'd like to intervene. Otherwise, I'll go ahead. Right, just on the side of the investigations, I certainly would have done an MRI for this patient. Yeah, Marcelo. Go ahead.
Thank you. I don't know if I hear very well, but the CH99 is very high. It's 400. It's true.
Yes, what I've seen from the hepatologist, that was 467. Yes.
It could be from cholestasis, simply.
Yes, it could be. She actually had.
Could be, yeah, or it could be a hepatocolangiocarcinoma. It's another possibility.
But it was biopsied.
The hepatologist had done a biopsy, transcutaneous biopsy, and it came back as a well-differentiated HCC.
Okay.
Now,
so before decided any surgery, I would stage the patient with a CT, a breast CT, to see if it is the stage of the tumor.
Sure. Alessandra has raised her hand.
I would like to ask if you biopsy also the right liver, the non-lesional liver.
No, we didn't do it. We had a forum with the hepatologist, and they said that we actually wanted to do that because this is actually the guidelines for a patient that has no diagnosis of cirrhosis. But they say that it doesn't look like cirrhosis. The radiologist had given their idea about it. So in the end, the decision was that there is no need for this.
In our unit, but I think there are many, we have to think about this presentation, not just for ourselves, but also for other people who see us around the world. So I think it's important to stress that when you biopsy a liver tumor that is suspected to be hepatocytic tumor, you also biopsy the non-tumoral liver, unless there are contraindications for that. And it gives you additional information. Ideally, one would measure portal hypertension, although there are methods today to infer portal hypertension, fibroscan, size of the spleen, or whatever, that can tell you about the presence of portal hypertension or not. But certainly, I would have at least ruled out that, staged the tumor in terms of chest X-ray, chest CT, and bone scintigram.
In the same order of teaching, You don't think there is indication today for chemoembolization is this kind of large hepatocellular carcinoma?
No,
No more.
on the literature, there is no longer indication for that unless you need downstaging of the tumor. But then a chemoembolization would not be my favorite one for that. In this case, but we can discuss it about it. We are here. I think that this tumor can be resected by a left hepatectomy. I don't know whether extended or not. We can discuss about that. I would have certainly wanted an MRI of the liver because I don't think that CT scan alone can rule out other small tumors today.
But look, the tumor are very near the main vessel. And by doing reduction of size of the tumor, you may gain some space between.
We can discuss about it. I think in this case, the tumor is probably encapsulated, and the more space you get on the pedicle of the anterior sector is space you wouldn't get anyway on the biliary confluent. So for me, there is no point in extending the hepatectomy on the anterior sector because you can't extend it into the biliary bifurcation. This is what I would do for this patient, but it's open to discussion. And I'm very willing to hear other persons about that. Who would do an hepatectomy extended to the anterior sector for this patient, and who would do a left hepatectomy?
So just to add, some of our thoughts, when we are planning, the worst or the most challenging resection, and we are discussing with the patient that it might end up in an extended left hepatectomy.
But then why didn't you embolize the anterior sector then? If you want to take it out, you may just as well embolize it. It's better.
What I was trying to say is that we were discussing some of the scenarios that might evolve during surgery. I agree with you that in this case, the safety of the patient will probably determine the decisions during surgery, and we will try to preserve the right anterior sector. But in case that we won't be able to achieve it during surgery, we may end up with an extended left just for that reason. It's probably going to be a close margin, as you mentioned.
Yeah. As you, does somebody else want to say something? Because otherwise I will go a little bit more deeply into the anatomy of this case. Who would like to say something? Otherwise I'll go ahead. Because unfortunately I can't see all the people who are online. It's limited on my windows to 8 people. If there is nobody else, I will go to, can you show me the anterior, the sector of the anterior pedicle? Right, exactly. So you see that sacrificing the anterior pedicle, in fact, does not really give you additional clearance on this patient unless you do something much more extensive, which is a resection of the bile duct. Because in particular, the posterior sector bile duct crosses around the pedicle of the anterior sector like this, and then goes down into the biliary confluent. So if you do, if you sacrifice a few branches of the anterior sector, mainly of the, let's say the anterior sector, it's not like that, it is like that, the anterior sector. and you may cut off a couple of branches on this side and leave the main anterior sector. But taking away the anterior sector here will not allow to negotiate the bile duct that comes with a turn of the posterior sector. So if you want more clearance, you have to cut the main bile duct and to reanastomose on the posterior sector, at least the bile duct, if not the portal vein, if you want that clearance. And I think that this tumor is encapsulated and you will get away with a left hepatectomy and not with an extended left hepatectomy. This is what I think.
Okay, that's great discussion that you mentioned, and very important considerations. I would like to ask you another further question regarding to your remarks. So in that case, what would be your strategy? Will it be a more aggressive, wide margin attitude approach, including resection of the bile ducts as if it is a Klashkin tumor, or you will intentionally go into a different strategy, accepting a narrow margin?
In this case of a patient with a big solitary tumor with no satellites and no signs of invasion of the biliary confluent, which I would investigate with an MRI anyway, I would not do that. If I needed to have more clearance there, I would resort to a chemotherapy or a radioembolization to shrink the tumor. But this is what I would suggest to our staff.
Perfect. Thank you.
I would like to hear other people because this is a nice, difficult case. I think that these tumors, in fact, are encapsulated and they compress the liver parenchyma on the structure. The capsule is not the capsule of the tumor, it's a compressed liver parenchyma.
Mm-hmm.
And when you stick to the Glisonian plane from the anterior sector pedicle, you go lower down, and if you stick very well on the hilar plate, you get enough clearance for these tumors.
Mm-hmm. That's what we hope.
You should carry on.
Okay.
We'd like to hear Bismuth on that, though. And we'd like to hear other people.
No, that means, Pietro, that you think that left hepatectomy is enough.
Yeah.
I think so. But curiously, I always think about the intervals of chemoembolization.
It's a big tumor for chemoembolization. I would do radioembolization or chemotherapy now.
Yeah,
if I can't do that.
What is the benefit in terms of neoadjuvant strategy, which means to reduce the size? What is the benefit of chemotherapy as opposed to immunotherapy?
Now, if I don't have a mean to resect this tumor, which you do have, in my opinion, then I think you should do it. But in this case, I don't think you should do it. If you have signs of multinodularity, I will give this patient a test of time and use chemotherapy or radioembolization to see whether metastasis appear somewhere. She hasn't got a huge alpha-fetoprotein, which is associated with vascular invasion. So I would go quite ahead.
Mm-hmm. Okay.
Right. Can we carry on?
Thank you.
Thank you very much.
Jean-Robert, would you have done a neoadjuvant chemotherapy for this case, or chemoembolization? Or as they did, portal embolization and resection, leaving the anterior sector. Jean-Robert has frozen.
I'm sorry. Probably chemo, because we have many papers in the literature now to show a benefit of preoperative treatment, but this is very debatable. And probably, as you advocated, a left hepatectomy. I think it's enough.
Mm-hmm. Good. Can you show us what you
Excuse me,
did?
Pietro. This is a decision you can take intraoperatively if you would do just a left hepatectomy or a three-sectionectomy, left three-sectionectomy. It depends on the ultrasound or everything. When after the liver ultrasound intraoperative.
Yes, but I would do all the anatomy of the bile duct. You can't keep the bile duct if you want more margin.
The middle hepatic vein is just close. It's close to the tumor. That's very, very, very tight to the tumor.
I
don't know
wouldn't worry
if
about the middle hepatic vein. I wouldn't worry about the middle hepatic vein. That can fall. That can go away. The right hepatic vein is big, and I wouldn't worry about leaving the anterior sector and taking away the middle hepatic vein in a patient who's not a living donor when you have to reconstruct it, especially if you've done the embolization before.
Another point is we can see just over the right pedicle, we can see the tumor is close to the right hepatic pedicle. I don't know if it is infiltrated at all or just beside the tumor. We can see the CT that we don't have a plane, a very good plane.
I thought you had it, but I would of course need more imaging and better time to look with it. I would like to see the tumor as you saw it the first time, and I think you can see the bile duct. I don't think the patient was not jaundiced.
No jaundice.
No, I think you have a plane on the hilar plate there.
By the way, this was the B embolization, liver venous deprivation.
Mm-hmm.
Here, this image. We can see, we don't see in this image a very good plane between the tumor and the right hepatic vein or the bifurcation.
What do other people think? I would need an MRI, a better look at the CT scan and all that.
Pietro, do you think now there is indication for a 3D imaging, reconstruction by 3D?
Indication not, comfort yes. But in fact, most of us are used to work with 2D and with not just with the reconstruction, with multiplanar CT, in which you can see the tumor on the coronal plane and on the sagittal plane.
But today, in your experience, in a case like this one, you will have do that?
I would certainly look at it with the different imaging, coronal and sagittal, but not a 3D reconstruction for this.
Okay. Okay. Pietro, Marcelo said that you have 7 cases to present today.
Yeah. So get on.
I don't know, you decide.
Yeah, but I would. So what did you do? Did you operate on this patient yet or not?
She is planned for surgery. Not yet. She
Right.
was planned next week.
So, anybody has advice for the team, for Nasser and Eran? No, I would do a left hepatectomy and not an extended left hepatectomy, and going right on the hilar plate and scooping out the tumor from the hilar plate.
Okay, thank you.
Jean-Robert, you would do a neoadjuvant chemotherapy for this patient?
Perhaps, yes. Perhaps.
Yeah.
There is an
All
ongoing,
right.
there is an ongoing trial.
Yes, but I'm waiting for the results.
Yes.
Thank you. So let's move on.
Thank you very much.
Thank you very much.
Hi, good
Henri,
afternoon,
will I be the
everyone.
moderator? I don't think I will be the moderator for the whole session, or shall I?
Yeah, continue. You continue.
Can I say something? This is Tom
Yes.
Cato. I'm sorry, I just joined a little bit late, but I'm doing a liver transplant today, and I haven't finished yet. So if you don't mind, if I can just go ahead and present now, so that I can go back to
Yeah, absolutely.
Okay, would it be okay? All right. So
It's very kind of you to interrupt.
No, it's almost tail end. We're just waiting for hemostasis, so it shouldn't be a problem. And we have a good other surgeon, young surgeons working on it, so it's not a problem. How do
You're as lucky as I am.
How do I share the screen? Is this
There is an arrow with a square with an arrow on which you can share your screen.
okay?
On the lower side of your screen, there is a little hand next to the
Okay. So then I can maybe go on this one. Okay. All right. So can you see the presentation?
Yeah.
Yes.
Okay, so this is a young patient, 23-year-old male with a history of colorectal cyst. He just came to me about 2 weeks ago, so I haven't done anything for him yet. So in the history, he underwent laparoscopic cyst resection and Roux-en-Y reconstruction at Sickkids Hospital in Canada at the age of 6, which is almost 17 years ago. So 17 years ago, to do a pediatric cystectomy, cyst resection laparoscopy is a very that time. Diagnosis was colorectal cyst.
We can hear it quite poorly. Can you take your hand away? Yeah, and close with the mic, please.
How about now?
Better.
Better? Okay, so I'm gonna be close to you. So this is a young patient, 23-year-old. Actually, no, let me put the earpod. Hello, is this a little better?
Yeah.
Can you hear me better?
Much better.
Okay, all right. So this is a young patient who just came to me 2 weeks ago. So I haven't done anything yet. He's a 23-year-old male with a history of colorectal cyst. So in the history, he underwent laparoscopic cyst resection and Roux-en-Y reconstruction at Sickkids Hospital in Canada at the age of 6, which is about 17 years ago. So do the pediatric cystectomy with Roux-en-Y reconstruction probably was a very early experience, but he had it. And the diagnosis then was a type 1 colorectal cyst, but he started to form intrahepatic stone soon after the surgery. They were just leaving it alone for the assumption there was no anastomotic issue. But he developed the first episode of cholangitis at the age of 19. And at that time, they decided to go ahead with PTC and transhepatic lithotripsy. And then he has had a recurrent cholangitis, recurrent stone, and this procedure over the past 3 years, about 3 times since then. So this is the CT scan. It's not the best images, but maybe you can see it. You can see quite dilated structure here and quite dilated biliary tree. And then there's a stone inside, you can see it. And then the PTCs are across here. And then in between the lithotripsy, he was tube free. So it's not that, he's always have to have a transhepatic tube, but that's, it's been getting the same procedure kind of again and again. And this is actual view. Resolution is not so good, but you can probably see it. So this is how it look. And the left side system is quite dilated. Right anterior system is also quite dilated with packed of the stone. But somehow right posterior system looks very clear from stone and not too much dilatation. This is probably the same thing. Okay, so I can go to the other one. Okay, so this is PTC images. And if you see the PTC images, I haven't talked to the surgeons up there yet. He just moved to New York, so he's gonna be followed here. But as you can see, it's kind of decompressed nicely. And it's not that completely, it's not that there's good evidence of anastomosic stricture. However, it seems to be functionally not well. And then as you see, the right posterior duct is relatively normal, but rest of them almost as if there's a cystic dilatation. And this is the picture. So you can see a little bit the right posterior duct relatively normal, but the anterior ducts are very abnormal, and then the left is abnormal. And then the packed with the stone. Again, the right posterior is a little bit of normal here. So the question to the team here is that, first of all, this type 1 cyst diagnosis back then was a correct one. Was that really type 1 cyst? But somehow it was operated as if there was a type 1 cyst. And I was trying to get a pathology and the OR report. I haven't had it yet. But if this is the type 4 cyst, what should be the right approach from here? And then third question is this, he may need a liver transplant down the line at some point, but when should we consider this type of patient for liver transplant? Suppose he's a type 4 cyst. And then the managing team in Canada, until he moved, he just moved to New York after he graduated from college. Managing team in Canada was telling him that he should probably continue with this transhepatic lithotripsy approach until the time comes. Then they would do a liver transplant. So that was the information he got from the managing team. So that's it from me for now. And I can probably unshare the screen.
Well, if somebody else wants to answer, otherwise the session transforms into an exam to me.
Okay.
Look, of course, when we look at the picture, we have the feeling that there is an intrahepatic dilatation that could be like Caroli. But indeed, in this case, it's not very peripheral. If we think about the Caroli, the extremity of the intrahepatic blood, which is not the case there. In addition, partial Caroline, it's only on the left there is the dilatation, not on the right liver. And partial Caroline is very rare. Here, what is, I may say, of the trunk of the branch, not of the small extremities. The small extremities are normal. For me, it is not this kind of congenital intrahepatic bile duct dilatation associated with the political system. Indeed, in this story, there was at the age of 6 and Roux-en-Y anastomosis. And when we took after the etiology of the stone as picture of the bile duct. So this is what we think first. It could be a partial stricture. Partial stricture is enough to induce the formation of intrahepatic stone. So I think we have to take this hypothesis in mind. That means since 70 years, the patient has a partial stricture with the formation of stone. What it means? It means that there is no disease. This is the consequence. No disease of the intrahepatic duct. And at that time, I may say no indication for extensive surgery. Now, if I propose some treatment, this is personal, I will be conservative. I have the feeling that there is mainly hepatic stone in the left part of the liver, and I may propose the section of the left part of the liver, mainly the left lobe of the liver, with a wide anastomosis on the contrast. It could be my primary proposition, but to be discussed among us.
I certainly agree. I would need also the imaging before the stent, the transhepatic biliary drain was put in, to see whether there was a kink in anastomosis or something which might have favored the formation of intrahepatic stones. Also, he's been clear from symptoms for so many years that maybe if you take away all the stones and you give also the oxycholic acid, then he may go for a long time without further problems. But you have to clear the stones and study the anastomosis. What we would do probably for this patient is extensive clearance with cholangioscopy. And look in all the bile ducts and go and fetch.
You mean intrahepatic, intraoperative, or just do it?
Percutaneous cholangioscopy.
Okay.
Yeah, with the spyglass.
Mm-hmm. That's probably what he has been getting. They clean up the stone, and then that's probably what he has been getting, because every time he was told the stone was cleaned on this past 3 occasions, but every time soon after that it forms the stone again.
I've been treated with oxycholic acid.
Okay. Okay.
May I ask you, when they did this maneuver to remove the stone, did he go to the anastomosis? Did he pass the anastomosis? The anastomosis patent?
Yeah, so, right. So this was all done in Canada, and he just arrived 2 weeks ago. So we haven't done anything yet. But just by looking at a cholangiogram cine image, it seems that at least, they were able to go through, and then catheter tip was in the jejunum. And also it empties very well. It's not like, obstructed. It could be partial obstruction, like you said. So I can show you one more time the cine image of the cholangiogram. Which is this one.
Yeah. Well, we can't see the emptying there.
It's not completely emptying, but it's empty.
Yeah.
So it's not.
Yeah, it seems very
slow.
good, but I would still do a cholangioscopy.
Okay.
with the spyglass.
Okay. So let's say cholangioscopy, and a cholangioscopy showed the very normal patent anastomosis. And is this really? Do you really believe that the Actigol or Usodiol can just prevent him from forming the stone again?
Yes.
Just high dose.
Yeah. The maximum dose, 10 milligrams per kilo per day.
Okay. Well, we can check on him what he has done so far. He may have already taken it. I can check.
In which case you are running out all the things you can do.
Mm-hmm.
And if he keeps doing stones and cholangitis, he'll end up with a transplant.
But how about this? You know, like Dr. Bismuth said, because there are very normal appearance duct here, but right anterior section is not normal, but right posterior section is very normal. So I wasn't really going to do the surgical resection, but if you do resection, the drainage might be better. Or
Yes.
even if you don't do drainage, even do the resection, if you get a much wider anastomosis, because probably it was laparoscopy, probably he was only 6 years old, so anastomosis caribou may not be that big to facilitate the drainage.
Yes.
Now,
I agree with you. I think the anastomosis is not wide enough for the migration of the stone. And my first proposal is to do something of the anastomosis. Look, it is not so large. It's patterned, but it's patterned for the bile, but not for the stone. And really, the aspect of the dilatation is dilatation of the bile duct, of the trunk of the bile duct. We may observe that, with a long-standing partial obstruction, a dilatation of the branch, but not the extremity. For me, I exclude an intrahepatic bile duct disease. It's dilatation of the bile duct could be mechanical.
Yeah.
Anyway, I will take this application to do the first step on the anastomosis without touching the but a complete removal, normally when we do that, we let a tube in the extremity of the vaginal loop in order to have a survey and repeated endoscopy to be sure we remove all the stone.
No, we can just make a short segment anastomosis of the duodenum. Is that what you mean? So that they can do almost like an ERCP approach to get up to the root.
You can, and if you redo the anastomosis higher up and wider, you can have a loop going close to the abdomen, to the abdominal wall, so you can access it from below, and that makes clearance of the further stones very easier.
Yes, yes.
Okay, but you're talking about stoma?
No. It's just a loop that can stick to the abdominal wall.
Just tuck it abdominal wall.
Percutaneous,
Yeah, so that's been done.
I've seen it in Paul Booth.
Yeah, that's been done in many other places, but somehow, our IL never want to do it. I've always asked them to do, they don't do it. So,
but, it is a young patient. It's a pity to let him with a tube, percutaneous tube. The proposal of Pietro is good, and to have this loop.
No, but how about a side-to-side anastomosis?
We did a lot of time in Paul Booth.
Okay. But how about a side anastomosis to your duodenum third portion? Just the root. Yeah, just the root.
So that you can access it with the RCP.
Right. Easily go up there.
I've been to abhor and to despise choledoduodenal anastomosis. And so it's not a solution to which I resort easily. But
Because
maybe I'm wrong.
It could be the food reflux is going to be an issue.
Yes. But there are two more senior people who've done them, and experience them much more than me, Jean-Robert and Henri. They know the problems and whether this would be a doable thing with advantage. Monsieur Bismuth, would you do choledochal duodenal anastomosis for this patient?
No, I will not do that. You know, I think that really, of course, if you do a new surgery with this patient, you have to redo the bilojejunal anastomosis. And by redoing it, you let a long extremity of the Roux in order to put systemically at the Pietro. And we did that in many times. We put, in order to have the loop directly under the abdominal wall. And very easily, with ultrasound, you find the loop and you puncture, the endoscopy puncture, and you go directly in the conference of the bile duct, and you enter in the right, in the left. You wash, you see, you remove the stone. And, you know, in your case, at the beginning, you have no stone in the small extremities of the intrahepatic bile, in the main trunk, which is very favorable of this case. So really, I think, by concluding, he has a long-standing disease with a lot of trouble to do surgery, to redo the bilojejunal anastomosis, to check the length of the Roux-en-Y. Sometimes it's short, and if it's short, it may induce reflux. Normally, I control the length of the Roux-en-Y in order to have 70 centimeters between the foot of the Roux-en-Y and the anastomosis, and to keep about 7 to 10 centimeters of the extremity of the loop attached to the abdominal wall. And that, only that. And then we see.
So, my question to you guys are, yes, that's probably the better solution. And when I was in Miami, but somehow Colombia guys don't want to do it. They never done it and they don't want to do it. But I may be able to convince them. So maybe this is the time I should convince them. But as an alternative, would there be a choice of jejunal duodenostomy, choledochal jejunostomy, not the choledochal duodenostomy, but just attach the root, part of the root, lymph, to the duodenum so that the endoscopy can easily go up to the liver?
I see what I mean. Yeah, I see what I mean.
So could that be an alternative?
Never seen it, but it's an intelligent idea.
Angios.
Because at least you don't have to go through the ligament of Treitz and then go up to the liver, which is a much harder endoscopy to do. But if you can just go duodenum to jejunum and then liver, it would be faster. But is that still going to be food reflux, maybe an issue?
Yeah.
If it's not long enough. Or if it's long enough, maybe it's not an issue.
I've never seen it.
Look, you have to discuss this with the endoscopists. If they are familiar with the thing, it is long in order to go to duodenum, to cross. And you need, anyway, to let a long jejunal loop. If not, you have duodenal reflux into the bile duct. So it's not good. I mean, if you let 70 centimeters between the duodenum, and you take a lot of jejunal, and then it will be not easy for them to go so long to enter in the bile duct. And you have to see with them. If they are very expert and if they say to you, it's okay, we do it, why not? It is easier. I agree with you. For the patient, easier than to have the puncture. But I tell you, the puncture is very easy. The puncture of the loop percutaneous is very easy.
Easiest. Okay.
And then you are online. You're not retrograde all the way up.
Yeah. One more question. This is my last question to the team. How do we rule out the possibility of potential carcinogenesis of the biliary tree? Does he have it, or we can safely say that he doesn't have the chance that he's going to develop cholangio? or he has it anyway,
In
then
theory,
you need a
they
surveillance.
have lifelong risk of cholangiocarcinoma after operations of colorectal cysts, and the pediatric literature says that it should be followed up lifelong. So there is a small risk, but it is small.
So in that sense, if that's packed with the stone, radiologists would say they would never be able to see anything. There has to be at least clear, or just do endoscopic surveillance, like you suggested. And then endoscopic surveillance should be done like annually, or is that like every few years?
I try to translate the recommendation on the pediatric literature into something practicable, and in fact, is ultrasound and MRI.
Right. But
Now,
if
here, in which case you would have, and there was no recommendation about the intervals when I did this review. But in this case, how often you would do the endoscopies, I don't know.
Yeah, I had not exactly the same case, but also another woman of the mid-age had a long time from the Roux-en-Y procedure and had a stone formation. And then somehow during the follow-up, she developed the cancer. But cancer was not in the bile duct. Cancer was in the jejunum side of the anastomosis, which was very interesting. I don't know why. And I removed it, and she's fine. But since then, is there any sort of potential? This is a totally different case, but is there any potential cancer development in the jejunum side, or this should not be the case?
Never seen it.
For me, never heard about that. But about the risk of carcinogenesis of the bile duct when there is cyst of the colorectal cyst, it's mainly in relation with an abnormality of the junction. About the pancreatic, the biliopancreatic. Here is the, and when we operate on the colorectal cyst, sometime in adults, and when there is abnormality of the junction, the risk of cancer is high. But I don't think if this does not exist, and if we do surgery, and it was a good surgery for they removed the cyst, and they did jejunal anastomosis, biliojural anastomosis, which is good for I think they removed totally the cyst. You have the operative report about the resection of the cyst.
Yeah, we haven't had it, but I'm obtaining it.
Okay, you check if they let inside to the cyst, which is very bad. I hope they remove the cyst. And you must remove the cyst totally, even going down into the pancreas. I have one case that, unfortunately, I have to reoperate on a young patient for they let half of the cyst inside the pancreas. And this is a risk to develop the cancer. And I do the surgery to remove this remaining part of the cyst, the lower part of the cyst, inside the pancreas, which is not difficult. Okay, you have to see that.
Yeah. Alessandra, raise a hand.
Thank you. I just wanted to say that I saw also a patient that developed carcinoma from an hepatocogenostomy. That this patient had several, like 15 years before. So in my little knowledge, having an hepatocogenostomy early in life was an itself a risk factor for developing cancer later.
No, I may answer to this question. No, but we have a lot of patients with biliary stricture, benign biliary stricture, that we follow for many years with biliojejunal anastomosis. There is no risk. If your question is the biliojejunal anastomosis is a risk for renal cancer, I think, Pietro, you agree, and Jean-Robert, I think we say no. We have a long story.
The pediatric literature says that operations after colorectal cysts, yes.
this is different. This is what the question.
And
Your
that's all
question,
Alessandro's question.
generally speaking, you say about bilogical anastomosis. This was your question, no?
No,
Alessandra.
yeah.
Yeah, that was the question. Because like the origin of that was the effect of the bile passage on the jejunum.
No.
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 Like chronic inflammation. No.
No. Right. Shall we move on because we have other cases?
Thank you.
Jean-Robert has a case. Jean-Robert.
Jean-Robert?
Oui.
Yeah, Jean-Robert, you can go
So,
ahead with your
Well,
case.
it's a short clinical case, quite anecdotic, but I think this should be useful for somebody one day during the career. I try to share my screen. So, présenter.
Yeah, it's working.
Alors, je vais me mettre. Vous voyez, you see my slides?
Yeah.
Yes. It's okay?
Yeah, it's not completely okay. Yeah, great.
So it's about an anatomical description of the vein of the pancreas. This is the inferior left vein of the pancreas. And this is a very important vein, constant, rarely described in textbooks. But if you see Quinault in the anatomy of the abdomen, you see that Quinault described very well this venous system and the splenic vein, and this is a very important arcade here. So the case is a woman, 50 years old, with a good performance status, recent diabetes, a severe jaundice, and the CT scan show a pancreatic tumor near 40 millimeters diameter, metal stent first, before any discussion, unfortunately. And she was initially considered as resectable, and PD was scheduled in another center. She was referred for a second opinion in my department, and I see the patient with this CT scan. And you can see here the portal vein, the splenic vein, okay, the celiac trunk. The confluence of the portal vein and the splenic vein is patent. And you can see here a major thrombosis of the superior mesenteric vein. So anyway, the pancreaticobiliary was scheduled in another center, but the recommendation today is not to operate this patient up front. So we have a short segment of patent superior mesenteric vein, but the trunk is almost totally thrombosed. Another view, this is the stent, the tumor, the SMV thrombosis here. But you can see on this CT scan, there is no cavernoma. And this is very interesting. Another view for the inferior colic vein here, the jejunal vein here, and the confluence of the ileocolic vein and the jejunal vein was patent. This is the schematic view of what we see on the CT, the two major trunks here, ICV and GV here. Another view. And this is a schema I wrote after my consultation. I see on the CT a huge pancreatic vein, like on the anatomic view I show you in the first slide. And this is the schematic representation of the CT scan. So MRI, no liver mets, some prognostic factors, severe jaundice, lymph node ratio huge, more than 3, recent diabetes, which is per se a bad prognostic factor. These are demonstrated in meta-analysis, and the CA99 was more than 1,000 after biliary stent. So I don't understand why the PD was scheduled in the other center. Locally advanced, probably. What is surprising on the CT and what strategy? And I can tell you that, shame on me, I did not see what was very surprising when I saw the first CT scan, because there is no cavernoma, a complete thrombosis of the superior mesenteric vein and no cavernoma. So, total absence of cavernoma, which is expected, usually, like in this patient. This is Ishikawa 5 or Nakao PV3. You can see here a thrombosis of the splenic, the mesenterico-portal trunk, and the huge arcade here, and the cavernoma with the gastroepiploic vein here. This is a very indirect sign of cavernoma, and you will see here the pancreatic arcade. And in the case I present to you, there is no such imaging. So why? No cavernoma, no tumor on the left side of the vein, free SMA, thrombosis not enhanced by contrast, but perhaps old SMA thrombosis, because in pancreatic cancer, we know that many prothrombotic factors are present in the patient. And what strategy? I think that we can
yes.
go rapidly, because the strategy is today is no discussion, I think.
Yes, she should have had the neoadjuvant chemotherapy. But I'm very interested. Why not the cavernoma? Because she must have a collateral somewhere.
Yes.
If she hasn't got the cavernoma. And the fact that it's old is not enough, because old things can have anyway. Sorry.
Okay. So we do a neoadjuvant chemo, indeed, 6 FOLFIRINOX. The performance status was good. We have a biological response with CA99 less than 400 and a short reduction of the lymph node ratio. But the CT was stable, and we do a laparoscopy for the evaluation of para-aortic lymph node. Because we think that in such a patient, the para-aortic lymph node are positive. Probably it's a metastatic disease, and the resection, even if the patient is responded, the resection is very debatable. At the end of the staging, para-aortic lymph nodes were negative, and we opt for radiochemotherapy. Why? Because a huge French experience show that results are better in the group of locally advanced treated by chemo and then radiochemo than chemo alone. So, because we do a huge contribution to this study published in the Annals of Surgical Oncology, we do a radiochemotherapy. This is the planning of the surgery after the radiochemotherapy, because the patient was biological responder and she was good, and we plan to operate the patient. This is the anticipation of the operative view. There is no cavernoma, but you can see here, like I show you in the anatomical slide, my first slide, we can see here the inferior mesenteric vein, and this vein, which is very, very important, is the inferior border of the tail of the pancreas. This is the operative view. This is the cutting of the cut of the pancreas. Okay, this is the confluence of the splenic vein and the portal vein. Another view, better probably, where you can see here the ileocolic vein, the jejunal vein, like in the CT scan, the terminaison of the superior mesenteric vein, the portal vein, and the splenic vein. And this is the section of the pancreatic body. So what I do, once again, is debatable, but I do a stapling of the short segment here of the patent SMV, and this is the operative view after this section and the mobilization of the specimen. This is the inferior mesenteric vein. I resect the staples preserving the confluence of the ileocolic vein and the jejunal vein. And after this, another view here. This is the inferior mesenteric vein. Here you can see a huge vein going to the pancreas here. No cavernoma, no collaterality. And I think I have to wait because it's curious. This is the schema of the operative field. This is the specimen, okay. The portal vein is here. The splenic vein, a huge gastric vein, like it was described by Nakao. And this is very interesting because sometimes the gastric vein go to the splenic vein, but sometimes to the PV or the confluence of the PV and the splenic vein. And you see here the inferior mesenteric vein with this huge vein here going to the splenic hilum.
Jean-Robert, there is a sign also of the inferior mesenteric vein going to the splenic vein.
No.
Or that was on the drawing before. One sees that there is a junction between the EMV and the SV behind the pancreas.
No, this is, sorry. This is the SMV, ileocolic vein, jejunal vein. The inferior mesenteric vein is here, okay?
Mm-hmm.
Now it's better view here. This is the pancreas. This is a schematic view. And this is the operative field after half an hour. The right colon was normal, the transverse colon was normal, and the small bowel was strictly normal.
Look,
So,
okay. Now, Robert, if I may say something, according to it, there is surely a portal circulation. It could be on the left, I say Pietro, through the adrenal vein, going from the adrenal vein going to the gastric circulation. But usually, we observe this in the children with portal hypertension children, extrahepatic block. There is collateral circulation. apparently there is no collateral circulation.
Yes.
Of course, I don't, it's curious, but I was expected in my life to look up one anastomosis that I know, but not in human, in animal, which is a spontaneous anastomosis between the extremity of the inferior, of the superior mesenteric vein and the iliac vein. This is observed mainly in the chicken. And yes, sometimes I say that chicken is a little mad by a kind of a natural encephalopathy by this kind of anastomosis. But my daughter, which is vet, observed that in the cat. And she removed this spontaneous anastomosis between the superior vena cava and the iliac vein. This exists in some species. I never observed in the human. But why not? Could be. I don't know. You have to show us this.
Yeah, but one thing could be that everything is going through the colic arcade. That this the whole bowel is draining through the colic arcade.
This slide is very interesting because I know why, but I am going to do a reconstruction, probably with a graft. I think perhaps the best is to do a venous graft, but I wait because about 1/4 of an hour, this is the bowel after the resection immediately, and this is after 15 minutes. And after 15 minutes, all is very normal. You can see here the end of the small bowel, the transverse colon, the right colon, all is okay. The transverse colon is perfect. And so I decide, this is the postoperative scan, I decide to do no reconstruction. No reconstruction, and
Jean-Robert, everything is going through the colic marginal veins and the colic arcade through the inferior mesenteric.
Yes, and then this is the postoperative CT scan, and then the splenic vein, and here the pancreatic vein, and going to the gastric vein here, and the portal vein.
Yes. Portal vein, yes.
So this is very interesting, and I have only 2 patients in my career, such this case, but I think it should be useful for somebody one time. So the patient had a huge tumor, this is very important factor, a very bad response to neoadjuvant chemo and chemoradio because TRG was 4, and she was IPT3N1R0, poor differentiation, moderate, neural and vascular invasion. This is very bad. Lymph node ratio quite huge, and venous invasion, of course. It was invasion of the vein and not thrombosis, benign thrombosis. Postoperative course was uneventful, despite a short sinusitis. Hospital stay, because I have this concern, was 15 days. Disease-free survival was 6 months, and after 6 months, the patient had metastatic liver disease and pulmonary. And she died 15 months after the surgery without any local recurrence. The literature shows some papers like this with SMV resection without reconstruction for pancreatic gland cancer or neuroendocrine tumor, and this is anecdotic but quite interesting. Thank you very much.
Very, very interesting indeed. Thank you very much. Jean-Robert, I don't know whether there are any questions, but otherwise I suggest we carry on. Who has other cases to present?
Alexandra, no?
Yes, but I didn't want to serve myself first.
No, no problem.
Let's get on then. Alessandra, your turn.
Yes. Do you see the screen?
Yes.
Okay. So this is the case of a 60-year-old woman with no relevant past medical history. She mentioned a slight venous insufficiency of her legs. She was a previous smoker. She stopped a few years ago. And she presented with some epigastric and back pain for a few months, no weight loss. So her family doctor asked for a CT scan. I hope you can see these scans. Can you see them?
Mm-hmm.
Okay, we see the arterial phase. There's something here, probably. There's no dilatation of the bile duct, no dilatation of the Wirsung. And this is the venous.
The venous, we can't see it scrolling. Yeah.
So maybe I just go on. These are some screenshots of the venous phase where we can see hypodense nodule just on the posterior face of the head of pancreas. And she had an FAS biopsy of this mass, which showed an adenocarcinoma. We completed with an MRI where we can see better the lesion on the posterior part of the head of pancreas. And she didn't have any secondary lesions, and the CA-19 was normal. So the particular thing in this patient is that she has a replaced right hepatic artery from the SMA that we can see here coming from the SMA just inside the tumor, which is here very going up to the origin also of the celiac trunk, then going down again and into the liver. So the only artery, hepatic artery, is going right through the tumor. So what would you say about this patient? Would you consider not resectable? Would you ask for other investigation? Would you do a neoadjuvant treatment or an upfront resection with an arterial reconstruction?
So there's no main hepatic artery. Everything is replaced?
Yes.
Yes.
No other hepatic artery.
I think there is no discussion.
What we did.
I think
yes, Jean-Robert. In fact, we asked Jean-Robert about this case as well.
we have recommendations today for such patients. They must have neoadjuvant treatment, despite the normal CA-19 and the good performance status. Before the discussion, the technical discussion of the arterial reconstruction, we have to treat the patient before to plan some surgery. And then after neoadjuvant treatment, we have to discuss how to do the resection and the reconstruction of the total liver blood inflow hepatic artery, right hepatic artery.
Yeah. So this is Jean-Robert. This is what we did. In fact, Jean-Robert is very kindly tutoring us for advanced pancreatic surgery. So he knew the case, and we did the neoadjuvant chemotherapy.
Exactly. So we ask first of all.
Alessandra, go ahead.
Yeah, we ask first of all for a PET CT, which showed no other captation but in the tumor region, And the patient had 3 cycles of FOLFIRINOX with a very excellent response on the new PET-CT that she has just a few days ago. She also performed an MRI which didn't show any suspicion of a secondary lesion. And I hope you can see this movie. This is the CT of the PET-CT, where we can see the right artery, which is still inside the tumor. So on the left, we have the situation before, with the quite a big nodule and the artery as we have seen before. And on the right is the new CT, where the artery is still in the tumor. The tumor has shrinked, but the right artery is still inside. So the first question to the team is if you will go now for resection or continue neoadjuvant treatment for 6 cycles, or add chemo or radiotherapy. And the second question is how the technical part, as we said, how to resect and reconstruct this inflow.
Right. Jean-Robert.
You hear me?
Yes, very well.
Yes. So the first point in this very interesting case is that you show that PT scan before neoadjuvant treatment and after neoadjuvant treatment is mandatory, because today is the better way to assess the response to treatment. MRI is quite good with the ADC coefficient, but PT scan today is the better way to assess the response to neoadjuvant treatment. This is the demonstration. The second point is a very difficult question. Chemo, 6 cycles, okay, of FOLFIRINOX, but chemo and then radiochemo, the decision is very difficult. Why? Because in France, we have a huge comparison between patient having chemo and patient having chemo radio. And the paper published once again in Annals of Surgical Oncology shows that probably it's better to do radiochemo after chemo. Why? Probably because this induced a long period of observation and a dropout of patients going to be metastatic. But in the literature, there is a huge experience in the United States and a huge experience in Japan, and the results are contradictory. So my point of view is it depends of the clinical status of the patient, but today we have no randomized trial, we have no answer to the question, and probably if the patient is responder, good responder, with a good response on the PET-CT and the CA99, perhaps with the plan of an arterial reconstruction, perhaps it's better, in my point of view, to don't do radiochemotherapy. This is only my opinion. And then for the reconstruction, the discussion is open. I think in the audience, people said we have to do a graft, we have to do a direct reconstruction, we have to do a venous graft, perhaps, but in my point of view, the much I'm sorry because I don't speak very well, but the easier method is reverse splenic artery. And I have 2 cases strictly the same of your case, Pietro and Alexandra. And the 2 times I do a reverse splenic artery to the hepatic artery, and he does very well. So, but this is very debatable.
Yeah. And we debated this case with you beforehand. In fact, we were thinking about a saphenous vein on the right renal vein because of being relatively distant from the anastomosis, of the pancreatic anastomosis. We do a separate Roux-en-Y loop for the pancreas to separate as much things as possible. And this appeared to us the most likely reconstruction. But I would like to hear other people as well. And thank you very much for the advice on the chemo radio and chemo only. We would continue until 6 cycles of FOLFIRINOX, I think, even if the response is good now. Any other? Tomoaki.
Yeah, I have to go soon, so I'm just gonna comment one thing that I think I agree with Dr. Del Pozo about the not doing radiation because of the risk. And I've been doing such complex arterial reconstruction cases using pancreatogastrostomy instead of separate root. So that might be another thing to separate the anastomosis quite far from the arterial reconstruction. And then arterial reconstruction, when I do ex vivo surgery, I've been using saphenous vein and quite satisfactory outcome. And a saphenous vein, you could also go directly to the aorta. You can do aortic conduit, and that can also be a great inflow. So you don't necessarily have to depend on the stamp of the SMA, the branch. So that's also could be another significant advantage of using saphenous vein. It's a long and durable, and it's really easy to do anastomosis. Sort of that's my recommendation. Maybe pancreatogastrostomy and then aortic anastomosis and to the hepatic artery with using saphenous vein.
Alessandra's raised her hand.
We had a little concern about using saphenous vein in this patient because she has a venous insufficiency. So she didn't have angiology examination yet, but there is a possibility that we cannot use her saphenous.
Well, but venous incompetency usually the valve issue rather than the vein strength itself. So you may still be able to use even if it's dilated. I have never been in that situation, so I can't comment too much, but maybe some other surgeons here may have had an experience.
Right, we'll see on that. Thank you very much indeed. If no other comments, Jean-Robert, many thanks for tutoring us anyway. It's
pleasure.
Thank you. Let's carry on. Another case.
Thank you very much. I will go back to the operating room. Thank you.
Thank you. Do we have any other cases? And Henri?
On vous entend pas, monsieur.
Henri a figé, je crois. So if there are no other cases, I mean, can I see other people saying that they don't have other cases? In which case, I think we can close this very interesting session. Jean-Robert, your presentation of the venous collaterals was absolutely wonderful. And Henri asks that we should summarize a moral or a little lesson of the staff each time, and that brings me back to you. You underlined that something we should have expected was not there. And one of the things I say to my residents is always much more difficult to find what should be there and is not there than to find what is there and should not be there. And it requires a lot of thought about that. And I daily recommend it to myself and to my junior staff. Look for the absence of things. Yeah, this is really high standard radiology. The presence of things that should not be there is easy. So on this, I think we would close the session. Thank you very much to everybody. And Jean-Robert will keep you posted on this case as well.
Yes.
Thank you very much to everybody.
On n'entend pas, M. Bismuth.
Non, je pense qu'il a complètement figé.
Il n'a pas son microphone ouvert.
Ah oui.
Non, mais moi, il n'a même pas son image qui bouge.
Si, elle bouge.
Oui, il bouge, il parle encore.
Elle parle. Ah.
Alors, il fait des commentaires, mais...
Monsieur Bismuth, on ne vous entend pas.
Chez moi, elle ne bouge même pas. I believe we should then end up the session. Thank you very much to everybody.
Thank you. Ciao.
Ciao.
And you tell us, Eran and Nasser, what will happen.